Good afternoon, council members. I see that we have live from Mendocino County, Mayor Darrell Steinberg, who is going to kick off the meeting with some remarks. And Mayor, won't you lead us in the pledge?
Councilmember Harris, Vice Mayor Harris, I'm glad to see you sitting in that chair. Why don't you lead us in the Pledge of Allegiance, please, sir?
All right, stand if you're able. Salute and pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible,
liberty and justice for all. Good afternoon, colleagues. I want to welcome all of you, and I am going to turn over the meeting to the Vice Mayor to run the meeting, but I want to make a couple of opening
Mayor,
remarks.
take roll first.
Oh, yes, of course. Yes.
Thank you. Councilmember Warren,
I'm here.
Vice Mayor Harris,
Present.
Councilmember Chenier,
Here.
Councilmember Guerra,
Here.
Councilmember Jennings,
Here.
Councilmember Carr,
Here.
Mayor Steinberg.
I am here.
And for the record, Councilmember Ashby and Hanson will be absent. Thank you.
Okay. Very good. Thank you very much, Madam Clerk. Thank you, Vice Mayor, Assistant City Manager Conlon, and my colleagues. I am going to turn this over to the Vice Mayor, who is the lead and the inspiration behind the very important proposal that we're going to talk about today. But I just wanted to make a couple of comments to sort of frame the discussion, and then I will participate, if you will, as a member, just like the rest of you. So first of all, a big thank you to the Vice Mayor for leading this charge to make sure that we have an aggressive methamphetamine response as part of our overall homelessness strategy in Sacramento. Jeff has been a dog on a bone on this for a long time, and it is his work that leads us to today's very, very important discussion. I want to thank County Supervisor Phil Cerna, who has been talking about this and working on this for a long time. I want to thank Jonathan Porteous, who I know is going to be one of our lead panelists here today, who's also led the charge on these sets of issues. I want to thank Kelly Fong-Rivas, my Chief of Staff as well, who has spent innumerable hours working on this important proposal in a very effective way, working with the Vice Mayor, and has led us to this day as well. Thank you, Kelly. And I'm going to leave out others, I am sure, but I mean to thank all of you. I just want to say that as we have tackled homelessness, and next week, by the way, on the 28th of July, we are going to have a thorough conversation about the various strategies, the 5-point plan, Project Room Key, the tiny home strategy, all the sources of money we have, which continue to increase because of state and federal intervention, and our various uses, the things you have all talked about and the things that are on the ground that are continuing that we need to build. The Vice Mayor reminds us constantly that if we don't deal with the drug problem around homelessness, specifically methamphetamine, that we are never going to provide the kinds of sustained relief for the people suffering, but also for our communities, because drug abuse and mental health are inextricably linked to our homeless problem. And we know, whether it's under the freeway, whether it's in the River District, whether it's in other parts of our city, that meth is a huge problem. And so this is the beginning of an effort to say, let's focus on this, not just as a side issue, but as a fundamental piece of our overall homeless strategy. And I couldn't be more pleased or excited to turn again the podium over to Jeff. I also want to thank SAMHSA, which is the federal agency that is responsible for mental health grant funding, but also mental health policy for the federal government. They have been a key partner to us in developing this agenda today, and will continue to be a key partner with us as we move forward with this and other initiatives. So Vice Mayor Harris, the show, so to speak, is yours.
Thank you, Mayor. I'm glad that you were able to attend. For the council members, I just want to give you an idea of what we're hoping to achieve here today briefly, which is to have about 8 speakers do small presentations to you about addiction and treatment 101, meth and the local impacts that we struggle with a lot that all of you see in your districts. And then talk about our proposed solution, which is called the SURE program, the Substance Use and Respite Engagement Program, developed basically with WellSpace. To get to this point, we engaged an awful lot of local experts, people who are very knowledgeable about the field of substance abuse and understand the repercussions of the use of opioids and methamphetamines amongst the homeless population, but also to try to make a nexus to the COVID epidemic and how these things tie together. As the mayor said, for us to be successful in reducing our unhoused population, substance abuse is a subject that we can't turn away from. When we did the railroad shelter, we found that at least 50% self-reported meth addiction problems, as well as various mental health issues. If you talk to any police person on the street, they will tell you that roughly 90% of their calls have some touch with methamphetamines involved in it. It's really a big and rampant problem in the city. I know that all of you as council members get calls about this regularly. If there's an elevated homeless population in your district, you certainly have had to deal with some of the effects of addiction generally, but again, methamphetamines is a particularly pernicious and evil substance that alters people's lives in a way that is very, very difficult to recover from. So we put together this panel of experts, and I'm very pleased to welcome them all. I'm going to tell you who's going to be speaking, and then we will just kick it off because we want to get this show on the road. Dr. Thomas Fries is a PhD from UCLA Integrated Substance Abuse Programs. Captain Emily Williams from SAMHSA, which the mayor alluded to, will be speaking. You all know Dr. Jonathan Porteous, the CEO of WellSpace and a big player in our local space, and Dr. Sean Benedict as well from WellSpace Health. Additionally, we have Jerry Miller, who's an assistant special agent in charge from the DEA District Office from the Department of Justice. Our own Bridget Dean, who I'm proud to say is the head of the new Office of Community Response. So congratulations, Bridget. I think that this is a great appointment for you. Lieutenant Sean Hampton from the county jail, Brian Jensen, who is Regional Vice President of the Hospital Council, Northern and Central California, Roseberry Younts, Senior Director, Behavioral Health Services from Dignity Health, and finally, Lori Miller, who is the Division Manager and Substance Use Prevention and Treatment Expert at the county. So welcome to you all. Thank you very much for attending this meeting. And Dr. Thomas Fries, can we start with your presentation?
And I actually think we're going to have Captain Emily Williams lead us off from SAMHSA, and I will follow her directly if that's okay with you.
That's fine, Thomas. Thank you. So welcome, Emily.
Hey, good afternoon, everybody. It's nice to be here and to be a part of your council meeting today. My name is Emily Williams. I am the SAMHSA Region 9 Administrator based out of San Francisco, and I cover the states of Arizona, California, Hawaii, Nevada, and the Pacific territories and jurisdictions that are affiliated with the United States. I'm here today to talk to you a little bit about the federal role in maybe some of the funding sources that you will need for your projects, as well as funding that's already available, combined with some of the best policies that people are really looking at. And then from there on, we'll pass it over to Thomas Free, who is part of our SAMHSA network and here to support your communities as well. So without further ado, I'm going to share my screen and get started. All right, can you all see that?
Not yet, Emily. It hasn't shared yet.
Okay, 1 second.
There we go.
Okay, great. Just wanted to really make sure that we have everything that we need going into this so that you know who I am, what I do, a little bit about me. And now, of course, it is not going to let me continue. Hold on. I really hate it when this happens. I want you to know that. I'm going to pause 1 second and try this again. You know, we practiced this yesterday and it worked just fine. Okay, here we go. Okay, just a little bit about myself and a little bit about what I plan to do. This is a photo of the regional offices that SAMHSA supports. Region 9 is your office here based out of San Francisco. There's myself in the office, and I have an assistant regional administrator by the name of Hal Zawacki. Some of you may have worked with him in a HRSA role through your health clinic there. The mission of the SAMHSA administration is to really reduce the impact of substance use and mental illness on America's communities. And I think that really plays well into what you're trying to accomplish today. You know, behavioral health is essential to health. There is nothing that is better than having well behavioral health, being healthy. Prevention works, treatment is effective, and people do recover when they have appropriate services. Here's a little bit about the SAMHSA organizational structure. As you can see, I was told you can all see my mouse. So the regional offices, here is where I fall, and that is underneath of the secretary of the assistant secretary, Eleanor McCants-Katz, who is the director of SAMHSA at this time. We have several different centers. We have the Center for Mental Health Services, the Center for Substance Abuse Prevention, Center for Substance Abuse Treatment Manager, and then the Center for Behavioral Health Statistics and Quality. And that's probably the least sexy out of all of them, but is the most important because we really try to run our programs in SAMHSA based off of evidence-based services and practices that really help to drive us as we're making policies that will be effective for communities that we're serving. A little bit about the continuum of mental illness and addiction treatment. You know, if you really look at it, you look at the prevention, promotion, prevention, then treatment and recovery. And that's a full continuum of care that's really looking at how that's going to support the project that you are looking at for your community, because you're really trying to support the beginning, the community prevention and health promotion, but you're also really looking at integrating healthcare into full healthcare into your services that will allow for rehabilitation and recovery support services by ensuring that unhoused people have access to services and care that they need to move towards recovery. This is a little bit of a, this is a very busy slide, but it gives an example of some of the opportunities that people have to apply for grants. And I know that California has many grants throughout the state, and some support some of the programs that you're talking about today. And I think that it just gives you an idea of opportunities that you can look at. Addiction treatments for homeless folks, pregnant and postpartum women's programs. There's a lot of opportunities for you to really look as a community for grant opportunities as they come out, and you can find those on the SAMHSA website under grants, and it's on the forward facing side. So when there's opportunities that come up that you're aware of, you can apply and be considered for those. I think that COVID has really impacted everybody's lives. It certainly has impacted mine. Who would think that I would be sitting in Alameda, California, speaking to the Sacramento City Council rather than being there with you all in person, really sharing a passion for the work that you're all doing in support of people that are unhoused within your community and suffering from substance use. One of the things that we're really finding and really hearing anecdotally, and from the East Coast, we're seeing some of the data that's beginning to come out, is that with behavioral health issues with COVID, we're seeing increases in domestic and intimate partner violence, increases in alcohol and substance uses, increases in overdose and overdose deaths. I was speaking anecdotally to somebody that's in prevention work in San Diego yesterday, and they said that their deaths related to methamphetamine are up 40% this year, so over last year. So there is definitely an increase. COVID has really brought out the increase in relapse. People aren't getting the recovery supports that they need. And it's definitely creating a lot of depression and anxiety in families and communities. I think that there's also a risk of underreported and unreported child maltreatment and elder abuse because people aren't getting out and being seen by folks that they would typically be seen by in your communities.
Yeah, could I ask a very quick question?
Absolutely.
Yeah, is that true across all age groups? So youth, elderly, we see a higher spike in some versus others?
We're really seeing some of the highest spikes are among elderly people who are really feeling isolated and alone, and young people who have missed out on some of the things that they really anticipated as they go through high school graduations, college graduations, and different things, that we're seeing more anxiety related to just the loss of that connection that people feel towards other people, and the loss of touch, that interaction that people have. So SAMHSA does have some very specific COVID resources that they have put out already. We received $425 million to increase access to mental health services through behavioral health, community behavioral health clinics, suicide prevention programs. And that has really made a difference in communities and tribal communities that were able to apply for some emergency fundings. I know that the state of California received $2 million in as based off of some of those emergency funds that SAMHSA was able to put out as grants that are supporting the suicide lifeline and some of the warm lines that you have here in California, and some of the higher impacted counties, not necessarily Sacramento County or Sacramento community, but in a couple of the southern counties that were more heavily hit by COVID in the beginning, I think is where California allocated those resources to. So there's some specific monies that have been set aside for tribes. I know that you have some tribal programs in Sacramento, and those tribal programs did receive an increase based on some of the emergency funding that was put out by SAMHSA to support their efforts with communities. There's also some expansion grants. $7 million went towards the Suicide Lifeline, which is to support everybody across the nation. There's a lot of challenges with COVID right now. It's very fluid. I mean, first we were opening up and now we're kind of closing back down here in California, and there's a lot of anxiety around it. There's specific resources for communities and individuals at the SAMHSA.gov website, and then just click on the coronavirus. There's a lot of support for communities in developing policies and evidence-based practices that will support the work that they're doing. These are some of the resources that are available through SAMHSA, and these are all coming out to y'all, so you don't have to like frantically write them down as we're chatting, but they'll all come to you in the PowerPoint after this is all closed out today. But these are resources that you really need to be aware of that are available in your community. I know that the SAMHSA Distress Helpline has had an 800% increase in calls over last year. So there is an impact on communities really trying to cope with and develop resources. And the National Helpline can really help people as they're looking for treatment and other resources within your communities. So these are going to come out to you. So take a look at all of them as they come forward, and really look at this site right here, the samhsa.gov/coronavirus. That will be something that will be a good resource for you and your communities. I'm kind of setting this up for the technology transfer centers. We spoke of just for a second to Tom Fries before. He runs the Region 9 ATTC out of the University of California in Los Angeles. We also have other technical and transfer centers here within Region 9 that are here to support your community and to support you as you develop policies and plans moving forward to really support the unhoused and people in need of mental health and substance use treatment in your facilities. Here's the information to reach those folks. I think that you'll find that there's a little bit, we have a prevention, addiction, and mental health technology transfer centers. There's also some national centers that are available to you. These are some of the others that are available for you. So I think that if you look at over here on the right, you have your homeless and housing resource network. Those are folks that are available to support you as you develop your plans moving forward. And then I really believe in fireside chats. So even though we aren't together, I think that the partnership and the information sharing that we're able to have and really support your communities and address the needs of the people that are living within your neighborhoods and the boundaries of your programs, that's why we're here. We're really here to develop a comprehensive public health model, and the public health model includes access to care from all folks and meet people where they're at. Okay, I'm going to turn it over to Tom.
Thank you very much, Emily. Mr. Mayor, Mr. Vice Mayor, distinguished council members, thank you very much for the opportunity to talk with you today. I'm honored to be here. My name is Tom Fries. I'm the co-director of the UCLA Integrated Substance Abuse Programs, which is located within the David Geffen School of Medicine in the Department of Psychiatry. And as Emily said, I'm also the co-director of the Pacific Southwest ATTC. And I was asked to share with you kind of an overview of methamphetamine and important issues for you to know, and most importantly, what do we do about it in terms of treatment? And so I'm going to share with you about 6 hours worth of information in about 10 minutes, and hopefully introduce you to some resources that you can use. In terms of timing, I do unfortunately need to leave shortly after my presentation today for another commitment, but we'll answer as many questions as I can in the time that I'm here, and I'm always happy to answer questions by email or in otherwise as well. So launching right into it, methamphetamine is a huge problem. It's a huge problem across the country, but as you undoubtedly know, more so out here in the Western United States. This map shows the greatest drug threat by geographic region, and the red bars across the country are methamphetamine. And so you see throughout the Western United States that methamphetamine really is the #1 problem. Even though if you ask a lot of people, we cured it a number of years ago and we just moved on to opioids, we know that it's never really gone away and in fact has very silently become a much worse issue. One of the things that we need to, two things from this slide that we need to know. One is there's really vast racial and ethnic differences in who's using methamphetamine and how people are using methamphetamine. If you look specifically at methamphetamine, the third group of bars there, per capita, the highest percentage use rate is among Asian Americans and American Indians and Alaska Natives, with other groups falling much below them. All of those groups still at high risk, though. I also want to point out to the council that we're really not just talking about methamphetamine, but a resurgence of stimulants as a whole. If you look at those cocaine numbers across the nation, they're much higher overall than the methamphetamine numbers are. Now, they are lower here in California than methamphetamine is, but we are seeing an increase in those numbers more recently. And so my concern is that those numbers are going to catch up. If you look at treatment admissions across the country, we know that treatment admissions have been increasing. That's the red bar here. But what's really concerning is this sudden uptick in methamphetamine treatment admissions. We know that treatment admissions are a lagging indicator by many years of the nature of the problem because people need to use long enough that something happens that they go into treatment. So that in the last several years, we're beginning to see that uptick is really concerning and an indicator that the problem has been around for some time. If we look at a little bit of California specific data, these are fatal overdoses in California, comparing the green line opioids to the orange line methamphetamine. And you see that opioids across California are still higher, but methamphetamine is very quickly catching up. And in some counties, the data shows that methamphetamine actually outstrips opioids in terms of the number of overdose deaths. This slide was presented at a California conference just yesterday by Marlise Perez at the Department of Healthcare Services, and I thought the numbers were really remarkable. If you look at overdose deaths in 2018, the numbers were almost identical statewide, one different compared to opioid overdose deaths. And if you map where the highest overdose deaths rates are, they map very closely. The opioid overdose map looks very much like this in terms of the darker areas being higher levels of overdose. They map very closely one to another. So it's a lot of rural communities in California that are suffering the most from methamphetamine. So, you know, there's a lot more data that I could share with you, but just as a highlight, it's a bad problem across the nation and it's really significant across the country. What I want to do is I want to spend the rest of the time that I have with you talking about what do we do about it. Methamphetamine, because of the way that it operates inside the brain, slowly changes the way that the brain functions and the way the brain is structured. It depletes dopamine and other neurochemicals inside the brain, and therefore changes cognition, it changes emotion, it changes motivation in very significant ways. Our treatment programs are pretty short overall, weeks to months generally. Sometimes if you're really lucky, you get as long as a year, often in association with the justice system. What this map shows is on the left, a normal control, and this is normal levels of dopamine functioning. So again, motivation, emotion, and some judgment related issues. This is a methamphetamine user 1 month post-detox, and you see a lot less red there, which means a lot less activity. Now, that goes on for quite some time, and we don't see a return toward normal, as in this right slide, until somewhere between 1 and 2 years. And so when we're talking about intervening with people who develop a methamphetamine use disorder, we're talking about really long-term intervention, very intense in the beginning, but then some capability of monitoring over the lifetime, over a long time, in order to help the person maintain the goals that they've achieved and continue to move forward as their brain continues to heal, again, over the course of 1 to 2 years. My slide seems to have stopped moving. There we go.
So I've got a
So-
quick question.
Yes, please.
Yeah, so the 2 years is you notice that that's when you actually see some activity. After 2 years, is there a sense of whether it's a linear or logarithmic, or what is the response like afterwards? Is that like the critical time 2 years, or is there?
Yeah, that's a really great question. That 2-year period of time is the time of healing, assuming that the person isn't using during that time. One of the things about methamphetamine is that some parts of the brain become desensitized to the drug, meaning in order to get the effects that they want, the user has to use more and more and more. Other parts of the brain become hypersensitized to the drug. So some of the mental health symptoms, some of the psychotic symptoms that we see, even a small amount of methamphetamine after they've developed some of these issues can lead to a return of those symptoms specifically. And so what we want is to get that person abstinent for as long as possible from their amphetamine use. But we know that's probably not how it's going to work. And so in the most ideal of situations, researchers are now saying it takes at least a year, maybe as long as 2 years, of no use for the neurochemistry to return back to normal. Now, that also doesn't mean they're not going to be left without symptoms, because we do change the way that the brain functions. We can image it and show that it's producing the right amount of dopamine, for instance, as in this slide, but there's kind of a symptom Russian roulette that happens for people. Some people will have transitory memory loss or occasional hallucinations or delusions. They'll have difficulty processing certain kinds of information, and you really never know what you're going to be left with. So one of the things we want to do in intervention is teach people the skills they need in order to cope with those deficits. Hopefully they can get rid of most of them, but keep the ones that they need in order to continue to live a happy and productive life. It's a great question. We can talk more about that at some point if you'd like as well.
No, thank you. That's very helpful. I appreciate it.
So everyone bemoans the fact that we don't have a medicine for methamphetamine. And it's true that we don't. There's been 38 or 40 compounds that have been tried that theoretically should have worked for methamphetamine, and none of them have been shown to be effective in reducing methamphetamine use, like the medicines that we have for opioids and alcohol. But we do have an intervention that's almost as powerful, and that's called contingency management. The use of reinforcers, generally monetary reinforcers, to directly reinforce pro-treatment behaviors. Now, this is a cocaine and amphetamine trial, and they looked at a whole bunch of different trials and said, what's effective out of these treatment trials? And what they found is that contingency management in some form showed better results than every other treatment that was evaluated. Another meta-analysis, 50 studies, over 7,000 patients looking at 12 different interventions. They found that the combination of contingency management with community reinforcement approach, which is both a cognitive behavioral intervention and one that tries to reshape the reinforcers in the community so that not using becomes more reinforcing than using does. That combination worked the best across these 12 different psychosocial interventions. And the research is also kind of zeroing in on the fact that we do get added benefit from other behavioral interventions other than contingency management, but we can't really predict very accurately what they are. They have a non-specific effect, and we need a lot more research in order to understand the specific components involved in how they work and why they work. And so contingency management, if I were recommending, we got one thing we can do, we've got a big methamphetamine problem, we should be doing contingency management. But here's the rub. There are federal restrictions that limit how we can use it. Because of concern about Medicaid fraud, any patient that receives Medicaid funding is the providers are prevented from incentivizing them in any way to come into treatment. We don't want to pay people to come into treatment so that we can bill more Medicaid. I get the whole concept. The problem is, as the Inspector General of the United States looked at this particular issue for contingency management, they said that the only way we can adhere to those regulations is if we provide incentives of no more than $75 per person per year. Now, the research was done with amounts at about $200 per person per year. Remember, methamphetamine is really highly reinforcing. And so we need a powerful reinforcer, at least in the beginning, to try to counteract that. $75 per person per year falls well short of $200 per person per month. We're going to try it anyway. I'm going to show you about an intervention that we're putting forward that I think has some hope. But I'm also hoping that, I don't know, people in the room that may have some political power also think about putting a message out to the Inspector General related to concerns about contingency management and the levels of reinforcers that are usable for Medi-Cal populations. There's a group of scientists right now, the leading scientists in this particular area, who are putting forth messages to the Inspector General asking for an exception for this intervention specifically. And I think any voices that we can add to that mix now would be very powerful in helping us be able to implement this the way that the science was done. But I'm going to tell you what we're going to do in the meantime, because we can't do that right now. So there are a number of other interventions that have been shown to have some effect. Again, the effect sizes are much weaker than what we get with contingency management. All have been shown to be effective in one way or another. And so what we've done through Rick Rawson, who is the person who developed and wrote the matrix model, which is very familiar here in California. It came out of our group. He was the director of our group at UCLA ISAP for a while. He's working on a program to pilot in 10 programs across California to begin with, just to collect some data on does this work or not, to see if we can put together an intervention that will use contingency management and still be effective in spite of the low values of those incentives. And so the TRUST program, treating users of stimulants, uses motivational incentives, not really contingency management, because we don't think they're powerful enough and we don't want to call them that as they were called in the research. But we're going to use incentives combined with cognitive behavioral therapy, community reinforcement approach, motivational interviewing, physical exercise, which has been shown to be an intervention in and of itself, and encouragement to participate in some sort of self-help group. Collect data on those and use that hopefully to be able to prove either A, that we need more powerful incentives, or B, that we can use this intervention and get a similar kind of effect out of it if we do it in combination in this way. We are going to be seeking programs to participate in this intervention. 10 programs, 5 will participate probably beginning in January. The other 5 will participate probably beginning in September of next year. It'll be an application process in order to be able to participate. And we do have a small pool of funding that will be able to pay the programs to offset the costs associated with the incentives and the staff time for training, etc. The materials that I just presented to you today are contained in a day-long program that the ATTC network is developing right now for training of providers. Our group at UCLA, myself and my co-director, are leading the development of this particular intervention, so y'all will have really direct access to it. It'll have a day-long training curriculum that, because of COVID-19, we're converting into a 3-hour virtual curriculum. It'll also have a series of 7 recorded modules that are 1 hour in length that will delve deeper into a variety of subpopulation related issues. And then 3 modules that will be specific to cultural groups, African Americans, American Indians, Alaska Natives, and the Latinx populations. We also have 3 different programs, and I grabbed the wrong version of my slide, so I only have one of them listed in here. We have 3 different programs specifically to offer training and technical assistance to pretty much anyone who needs it. There's the SAMHSA-funded Opioid Response Network and the state opioid response grants, both of which in the next round of funding will allow for treatment of services related to methamphetamine as well. And so for either opioids or amphetamines, we can provide training and technical assistance through the Waiver Prescriber Support Initiative, through the California Hub and Spoke System, or through the SAMHSA-funded Opioid Response Network. In fact, all of the money for all of those come from SAMHSA directly or indirectly. And I'll just leave you with a bunch of other resources, including how you can access the larger training as it goes along. So hopefully that information was useful. I'm happy to take any questions that anyone has. And I really am excited about the work that you all are doing and think that the center that you're all talking about setting up has real potential for having great impact on a population of great need. And I appreciate the opportunity to speak to you today.
Thank you, Tom. This is Vice Mayor Harris. You know, what we're aiming to produce here with our effort is sort of a first step approach. I think that we're going to show great efficacy with the respite engagement sort of approach. And the work that you're doing is the next step. You know, we are going to need partners as we get this thing out of the ground and up and running. And I expect that we'll be leaning heavily on yourself and SAMHSA you know, for advanced treatment models and moving the program forward. To my colleagues, I'd like to say that we have allocated $1 million of CARES Act money to start this program. I wouldn't call it a pilot because we are fully funding a real program, but we are going to have to look for resources to make it sustainable, and we are going to need the federal government as a partner to build this program to the point where it makes very substantial inroads. As you can see from the presentation, rehabbing people who are addicted to methamphetamines and opioids, of course, is a process. It doesn't happen real quickly, and as you saw, you know, for a brain just to revert to normal functioning can take 2 years. What we aim to do, Tom, though, is to work with our homeless population and, you know, who are addicted to methamphetamines and start a process by which they can be successful in a housed situation. So that is ultimately our goal. We know that addiction is really rampant amongst our unhoused community, and we'll be looking to you both for advice about how to work specifically with the unhoused population. Of course, that's not the extent of the problem in Sacramento or Sacramento County. Certainly people who are in housing are having meth issues as well, but that's where we see it. And that's where we see the behaviors on the street that we as council members have to deal with every day in terms of keeping our constituency safe, both those outdoors and indoors. That's what we're taking on here, and it's ambitious, but I'm very excited that we're underway.
I am too, and Mr. Vice Mayor, thank you very much for those kind words. And we are here to be a partner with you. We're funded by SAMHSA not to provide direct services, so that's what Emily was talking about before, but really to provide training and technical assistance so that you have the capability among staff people in order to be able to run those services. I am a firm believer that if you're homeless, you're probably going to use drugs. If I were homeless, I would use drugs and I would use meth. I've done a lot of work with homeless people on the streets. And if you've never been on the streets, and I have not been personally, but I've been very close to many people who have through the treatment services that I provided, it is much worse than anyone thinks. I think having an opportunity for that respite and then figuring out how to get them into care is the right first step for that. And we're happy to be here to share whatever resources that we can. We have funding directly from SAMHSA and indirectly from SAMHSA through the Department of Healthcare Services and through the American Academy for Addiction Psychiatry. And all of those resources are available to everyone in this room and to people across the state in order to address these needs.
All right, well, thank you very much to you and Emily both. I think for in interest of time, we better keep moving. Council members, you can ask questions, of course, after each presenter, but you can also hold them to the end and then have a more comprehensive discussion. So next, we're going to have Jonathan Porteous and Sean Benedict come up from WellSpace, because WellSpace is basically the foundation of our program and how we're going to start this. Jonathan, the floor is yours.
Thank you very much. Good afternoon, Mayor Steinberg, Vice Mayor, and the distinguished council. Thanks so much for having us here. I'm going to give you a brief overview of the kind of WellSpace Health program, and then I will offer up Dr. Benedict to get into the details of our addiction treatment continuum. I have the good fortune and honor to be the Chief Executive Officer of WellSpace Health, and we are a large regional provider. We are sort of an amalgam of many different organizations that have existed in the Sacramento community since the early 1950s. And we've blended that all together and woven that together to really try to provide a comprehensive blanket of care for our region. We're a nonprofit 501c3, and we also, since 2009, have been a federally qualified health center providing medical, dental, behavioral health, and supportive services through just the FQHC, currently to about 105,000 people in the region. Beyond that, our organization has extensive behavioral health services and community support services. And we are the largest primary health provider to the homeless population in our region, since we're both a primary health delivery system and the federal government considered us a homeless access point for health services for people who are homeless. Our mission is to achieving regional health through high quality comprehensive care. So the goal is to bring up population health in every population we serve by providing an integrated practice. We believe that everyone deserves to be seen no matter who you are, where you come from, where you work, or what place you call home. And at WellSpace Health, we see you. We do this through partnership. Everything we do since the early 1950s has been through partnership. I can't imagine a program that hasn't happened through support. We've just had Dr. Fries talk about the work that ISAP does. Many of our programs are founded on this evidence base that he and his colleagues have created. So that is a great partnership. So Captain Williams, I don't even know where to start. Hundreds of millions of dollars have flowed into our county over the years, from SAMHSA through the state into our county, and administered and delivered as services, ultimately SAMHSA supported services for our communities. These are both incredibly powerful partners for us, but we also are partnership with the city, with the county. We do a lot of work with the state and even the federal court system. And we have a network of 19 community health centers, 4 immediate care walk-in health centers, 7 dental centers, 3 specialized behavioral health centers, 2 medical respite centers where we do care transition out of the hospitals. We have a residential treatment center, which is a treatment center, residential care site for people with co-occurring mental health and substance use disorders. We also have a withdrawal management center, which is actually what used to be called a detox facility, and now is very fancy. It's called a withdrawal management center, which is a medically monitored facility where we're able to provide a med pack to help people step down as they come off substances. And then we have, as most of you know, extensive partnerships in sort of 14 other locations nested into housing environments, health environments, so that we can work on achieving regional health through high quality comprehensive care. You will see this map of our services, and we've tried to just create that blanket across the region. We believe in going to the communities where our clients are. And so we've made a great effort to provide services within the communities, many of which are communities where people have had limited access to services. I'll also note at the top, we run the 24-hour suicide prevention hotline. Thank you again to Captain Williams. We actually are a lifeline provider, the 1-800-273-8255 number, to 50 out of 58 California counties. Again, with enormous support and partnership with Sacramento County and the National Lifeline. So we are here as a broad service delivery for health and behavioral health services across our region. I, again, can't do this alone, and I'm going to transition to Dr. Sean Benedict, who's a dear and long-term colleague of mine who manages both of our integrated behavioral health continuum, which is behavioral health nested into all of our health centers, as well as our co-occurring continuum, which is that continuum of addiction and mental health services treatment that is outpatient, residential, withdrawal management, detox, medically assisted treatments, and will be partnered to this program that we're presenting today. Dr. Benedict?
Thank you very much, Dr. Porteous. I can't tell you what a pleasure it is to be here with the council today. This has been a long time coming for us. I remember sitting in Vice Mayor Harris's office, I don't know, maybe 18 months ago, and talking about what can we do about this. So this is very exciting for me to be here and to be able to talk to you about how we envision things. I think today my role is just to kind of briefly look at the local level and the nexus between the current pandemic and addiction, and how those two are interrelated, and how this project fits our attempts to work with both. I think the first thing, Dr. Freeze talked about this, I think pretty much everybody knows this now, that addiction is really defined as a disease of the brain. And as such, it's really a public health problem rather than a criminal justice problem. If a criminal justice approach worked towards addiction, we probably wouldn't be having this discussion. And I think that what's happened now is that the COVID-19 has brought this distinction into clearer focus, because we're looking at a major public health problem, maybe the biggest one since the discovery of HIV, where we're in a crisis, a public health crisis, and we're trying to find solutions to it. And since we have this nexus between addiction and COVID, this is really an opportunity, the SURE program, to bring it all into focus. So to give you an idea of the continuum that we have, Dr. Porteous mentioned the various levels: withdrawal management, residential, intensive outpatient, perinatal outpatient. We have criminal justice programs. We run programs inside Rio Casumas Correctional Center, for example. And during the first 6 months of this year alone, we've treated about 1,100 people. And that's just one company. So there's no doubt that this is a serious problem for our community. If you really think about what we call the negative trifecta of addiction, right, which is a higher level of co-occurring health disorders, homelessness, and criminal justice involvement. And these are important to consider because, as we all know, the co-occurring health disorders, high blood pressure, asthma, diabetes, increases one's vulnerability to COVID-19. We know that homelessness is also a high risk group because they don't have places to isolate. They don't have places to do the things that we're asking them to do to keep themselves and the community safe. And then criminal justice involvement is important because what happens to people when they're suffering from addictions is they have this sort of downward spiral as they get arrested for, say, a drug offense. Well, now maybe they're not eligible for a certain type of housing, or now maybe they're not eligible for a certain type of job, and they get hopeless and depressed, and they use again. And so this is a sort of coming together point of all these risks, which a recent paper described as the perfect storm, where this could be a community spread that we're not even going to be able to touch because the folks are not engaged in services anywhere. And that's what we're trying to do. We're trying to engage people. And by doing it earlier, by trying to solve the problem a little further upstream, we're hoping to prevent not only the spread of COVID through the community, but all the human suffering and cost that comes with addiction as well. And the bottom line is we know that people who are intoxicated are at higher risk of getting and spreading it. All we have to do is look at what happened when they reopened the bars. People who are drinking do not socially distance, right? So this is kind of the idea, the conceptual framework behind the SURE program, and we're really looking forward to getting it off the ground and going. So thank you.
Thank you, Sean. You know, I'd have to say it's been a real pleasure working with you and Jonathan on this project, and pretty excited about it. To the council members, I'd say this. I think we all know that using jails to deal with substance abuse and mental health issues is not practical. Additionally, taking individuals who are living on the streets to the hospitals over and over again is not working. So the SURE program is a place to engage these people and try to get them on the road to recovery, which again would potentially lead them to being successful in a house situation. I know that that is my personal goal, but I think that dollars spent on this are far better used than beleaguering our healthcare system, especially in light of COVID-19, where our hospitals are getting very energetic now with patients with coronavirus. So it's a pretty exciting program. And as I said before, the $1 million that we've allocated is going to get us up and running, to find a facility, to stock it, to get personnel to man it. But it is going to take more resource to make it sustainable long term. Ultimately, we would like to get licensure and use federal funds to continue operations and expand the program, because we know the need is there. But there's another piece to this too, which is working with our police department. They have said to me constantly for the last 5 years that they need a place to navigate people to that is not a jail, because as Dr. Sean Benedict said, this is a public health crisis. It's not a criminal crisis. And so we've been going about it, I feel, the wrong way, or at least in a way that's not practical, that is not getting to the heart of the issue and solving the problem. And I believe that this first step with the SURE Center is the way to get the ball rolling. Do we have any questions for either Dr. Porteous or Benedict? If we don't, then we'll move on to sort of more of what's happening in the local situation here in Sacramento. And maybe we can have Jerry Miller from the Department of Justice say some words about what he sees, and followed by Bridget Dean. Jerry?
Hello and good afternoon, everyone. I'm trying to start my video, but I don't think it's starting. But at least, hopefully everyone can hear me. Thank you, Vice Mayor and council members, for allowing me to come today and be here. As you've heard, my name is Jerry Miller. I'm the Assistant Special Agent in charge for the Drug Enforcement Administration here in Sacramento, but I'm also a community member, as are everyone who works in my office. So these types of programs mean a lot to us as well. So we're here to support you and your programs in any way that we can. What I'd like to do is read you some prepared remarks that I have that give you a broad overview of, sorry, there's my video. There I am. A broad overview of the national and regional enforcement trends for methamphetamine that we as DEA are seeing. And it'll be short and brief. Some of the information may be a little redundant, something you've heard already, but then I'll be available for any questions that you may have. So let me begin really fast with this. And I have to wear my glasses because I'm old. Over the past decade, we have talked about the opioid epidemic, and now we need to talk about the meth epidemic. Methamphetamine is the greatest drug threat in California. The drug, which has been prevalent in the West and Midwest, is now increasingly available in parts of the United States that historically have not been major markets for the drug, particularly the Northeast. And everyone was able to see that on that chart that was supplied earlier. Methamphetamine production takes place primarily in super laboratories located in Mexico and smuggled across the southwest border. These labs are capable of producing up to 3 tons on a weekly basis. The clandestine labs in Mexico are supplied by a diversion of large quantities of precursor chemicals. And these chemicals are particularly imported to these labs from China and India. California's I-5 corridor serves as a major thoroughfare for the drug as it makes its way to the distribution networks in the state and beyond. As availability of the drug increased, the price plummeted. That, coupled with an average purity of 97%, drug cartels flooded the United States with an extremely potent, cheap, and highly addictive drug. Once in the United States, drug trafficking organizations sell to established criminal groups and push this poison into our community. At the onset of COVID-19, DEA had identified supply chain disruptions of nearly all illicit drugs, both at the wholesale and retail level. DEA offices across the country reported select drug supplies were running low. Methamphetamine was a drug most frequently identified as shifting, with price increases at the retail or whole level. As the supply got low, the prices went up. I think that was a little confusing. DEA is aware of stockpiling the drugs and money on both sides of the southwest border. It is important to note that it is simply too soon to identify exactly what is causing these disruptions and how the virus and subsequent social distancing orders have changed drug trafficking across the globe. We can't say for sure if COVID-19 was responsible for that or not. Even with the recent disruptions of the methamphetamine supply chains, the drug is still widely available in the Sacramento region and throughout the state. In 2019, the DEA San Francisco Field Division, which we are a part of, it covers Bakersfield to the Oregon border. We seized nearly 1,300 pounds of meth. And year to date, we're at 825 pounds, and these are approximates. Other troubling trends we're seeing with methamphetamine are pills sold on the street that contain meth. It's not just pills that are opioids, these pills contain meth. These fake tablets are sold as Adderall or Xanax or other illicit controlled prescription drugs and are nearly indistinguishable from the legitimate product. Additionally, the majority of MDMA or ecstasy tablets we seized, they're actually meth pills. There are also increasing reports nationwide of fentanyl being mixed in with this. We have seen specifically in this area where fentanyl is mixed with any and all types of drugs, meth, cocaine, everything. The CDC overdose death report demonstrates that DEA is on target with placing continued and increasing focus on methamphetamine. According to the CDC, in 2018, overdose deaths attributed to methamphetamine increased over 22%. Unlike with opioids, as you've heard earlier, there is no overdose reversal drug that can be administered to someone on meth. We have the Narcan for opioid when they flatline, or if it kills someone, we can try to bring them back with Narcan, but we don't have anything for meth. DEA is combating methamphetamine trafficking through a strategic focused enforcement actions of larger networks operating in a region through coordinated efforts with law enforcement partners. We also established an OCDETF strike force, an organized crime drug enforcement task force strike force in 2019 to combine intelligence and resources with our federal, state, and local counterparts to target major distribution cells operating in the Sacramento region and beyond. We work in concert with our local partners on specific operations to disrupt and dismantle networks operating in high traffic areas. Supply matters. It is our job as law enforcement to effectively reduce the supply, not only to target those at the top of the food chain, but also those distributors in between. By reducing supply, availability is diminished. Partnerships at all levels are important to identify the biggest dealers in the region for federal prosecution and to use every tool available to bring them to justice. That's all of my prepared remarks. And I'm happy to expand on any and all topics that I can. And any information that I can't supply to you, I will get to you. Are there any questions?
Well, thank you, Jerry. I'd love to sit down with you 6 feet apart and have a more in-depth conversation about the supply chain in Sacramento. So I'll look forward to setting up a meet with you. Are there any questions for Jerry? It's pretty silent out there. So thank you for your time, and we'll be speaking more, and there may be questions for you at the end of the presentation. Bridget, are you available?
Unfortunately, I have to leave at this time. So if there's any questions, if you get me those, I will respond. I'm sorry.
Well, thank you for your time and coming today, Jerry. Much appreciated, and I'll be in touch personally.
Thank you, Mr. Harris.
Bridget.
Yes, sir. Thank you, Vice Mayor. Hello, everybody. Hope you're having a good afternoon. I'm just going to touch on a few areas that I think are important to talk about, especially with the direction we're going as a city right now. I want to start out by saying thank you to everybody who's been involved in this process. As we are talking about removing individuals out of the channels of criminal justice system and law enforcement contact, this is a great example of how we can do that. And so I'm just going to share a few quick slides on what that might look like and make some points on how important it is to make this shift right now during COVID. So give me 1 second here. So what I want to start off is just by talking briefly about our Office of Community Response. As you all know, I've recently been appointed as interim director, but the number one purpose of this collaborative office with our community members and our nonprofit organizations and county and city agencies is to reduce law enforcement response to non-criminal crisis and methamphetamine use in particular, especially right now where we're seeing increases in calls for service due to COVID, sheltering in place, our homeless populations. It's crucial for us to really start making that shift away from law enforcement response and get it into the hands of the experts in our community who are providers. And this is an essential piece of the program of community response, but more importantly, this program to me shows how we can do that. So overall, our goal is to engage in system collaboration. You've heard all of the speakers talk about how important it is that every system is collaborating. If we truly want to disengage law enforcement from a lot of the issues we're having in the city of Sacramento, then we have to collaborate together. Everybody has to be at the table. Our goal is to provide community access, outreach, education, referrals, resources, and supports. And again, we serve everybody in the city of Sacramento. Related to methamphetamine, you heard Jonathan and Sean speak about the different tools they're going to have just with the length and the span of work they've done with WellSpace. So I have two quick slides here, but I want to touch on, these are the top call types related to methamphetamine. Homelessness is not necessarily in here, but it's definitely a call for service in our law enforcement population, our department with dispatch. But what I want to point out is, look, please look at all the different areas that we're seeing methamphetamine engaged in. And I think it's important when we're talking about shifting our city into a social service model and collaborative community response to help people in crisis, that we understand that methamphetamine in particular represents an issue that is across the board in our city. Multiple people, multiple calls for service have a methamphetamine connection, and we can't ignore that. Medical aid, that's our fire department responding to a great deal of those. Our hospitals are being impacted. So we have to talk about how it's a wide span beyond homelessness, although homelessness definitely is an area we see the use in. And again, that relates a lot to COVID due to our all of our mental health and countywide behavioral health supports are doing the best they can with telehealth and some of those other tools they have in their pocket right now with COVID. But we must understand that for many of the individuals who need that daily or regular contact that they might have with a provider, just that lack of that even somewhat might be adding to the issues they're having with the drug use. And the other thing I just want to point out is really, where do we see use disorders in law enforcement? So 911 is, in our city, we still probably receive more calls related to substance use disorder within our police department dispatch than anywhere else in the city. And that is one of the first things we have to address. Having a center where law enforcement could either direct or warm hand off individuals in crisis with methamphetamine or other drug issues is essential to removing law enforcement eventually from those calls for service to begin with. So methamphetamine has increased with COVID recently, and yet law enforcement, as you've heard many people share today, are not the substance use experts that these individuals need to be working with. So a wide spectrum of individuals and communities have been impacted. I just showed you that with that slide showing the various calls for service. but just know that COVID is adding additional stressors to all of those areas. We've seen multiple things increase in the city as far as dispatch calls for service, and that includes domestic violence, family disturbance, and other issues. The access to services is limited and difficult for LE. Law enforcement isn't signed up to do the social service intervention. And that's where we as a city, I think, are on the front line of doing a model and creating a model that really supports individuals to get connected to the right people. So we need to engage them at the time of crisis. A sobering center allows that to happen. If we don't provide that type of service where it's in the moment of the crisis, then we create the revolving door within our criminal justice system for these individuals. And frankly, it increases the law enforcement contact. When law enforcement is the 24/7 access line for many people, we are creating the door, and we need to work together collaboratively with examples such as this sobering center to really allow another doorway for these individuals to enter into service and treatment. The one-stop full range hub, you heard with Jonathan and Sean, the range of services that can be provided with an organization like that. WellSpace is by no means the only organization in our city that can provide a breadth of services, but I think it points to the need collaboratively to work with multiple service providers and agencies to make sure we're touching all of the areas that are impacting that individual, as addiction is rarely, if ever, a single issue. And then, as much as I know a lot of people are concerned about an LE process and some of this programming, the reality is initially we have to have that door and have LE at the table with us to get them the warm handoff. If law enforcement is able to do that in that first contact they may have, there may not be any other subsequent contacts, because now that social service provider can take it from there. We know that it takes multiple contacts to build trust and rapport with individuals who are at crisis. And I think that, again, this sobering center is a perfect opportunity to start that ball rolling. And then finally, collaboration and the multidisciplinary case management that can be provided has shown to be successful for creating that long-term engagement for individuals. We need to keep doors open. We need to keep allowing that. Many of these people will go through a sobering center multiple times. We know that, and WellSpace is prepared for that. But we also know that each time it might get us that closer to long-term treatment and sobriety for these individuals. So that's a very short overview of the importance of this in our new plan as we move forward as a city to really support agencies, to support us, and to remove LE from a lot of the calls for service that they are currently engaged in.
Thank you, Bridget. You brought up a lot of really important points, specifically the warm handoff approach. We know that we need to keep drug addicts out of our jails, and never was it more important than now, since our jail is basically trying to reduce their population as much as they possibly can. So it's a tool that's really not available to us at this point. We need an alternative. And I'd like to bring up Lieutenant Sean Hampton from our county jail to talk about the impacts of COVID on the jail and the nexus points with the sobering center. Sean?
Good afternoon, everyone. Thank you for letting the Sheriff's Office have a seat at the table here and provide you folks with some information regarding our response in corrections to COVID and narcotics related and drug related offenses as we've kind of made our way through this process. This has no doubt been a definitely challenging time for all of us. And having spent 20 years with the Sacramento County Sheriff's Office, and most of the time that I've been with the office have been involved in street level enforcement, there's no question that we do have a significant methamphetamine and or drug and alcohol problem within our communities. So with that, I'll move forward and share my screen here with you. So if I can get this to come up. So are you able to see my screen yet or no?
Yes.
Hello?
Yep, we can see it.
You're able to see the PowerPoint presentation?
Yes.
Okay, perfect. So moving forward, we've compiled some information for this presentation, but for 2019, for our bookings, the total bookings we processed in 2019 were 34,713. And that's not individuals booked. That could be folks that were booked multiple times within our facilities. So 2015 through 2019, our public intoxication statistics indicate that we did process 3,500 per year on average. And that includes folks that were arrested for drunk in public and public intoxication, or 11,550, the health and safety code, which would be under the influence of controlled substances. Our average stay for folks who are booked into our facilities for those offenses is 12 hours, unless there are other mitigating circumstances. They're here for other warrants or whatever it may be. So in early March, we approached all of the agencies and our agency partners in the region and requested that they cite and release all eligible misdemeanors in the field. And this was done to mitigate the potential of COVID coming into our facilities, both the main jail and the Rio Casumas Correctional Center. We encouraged them to scrutinize misdemeanor intoxication arrests and other misdemeanor arrests, and do this based on 4 criteria. Those criteria being that the likelihood the crime would continue, that the arrestee or the person they were in contact with was unable to care for themselves, and there was no other place to take them other than a hospital. And in some circumstances, hospitals, as we've discussed, are not the appropriate place to place some of these folks, although they may receive some treatment there. We wanted to make sure that they use custody only as a last resort. And this was something that we worked with all of our agency partners with, and continue to do so as we work our way through this pandemic and process the information. And I'm sure everybody else can agree that there are a lot of processes that change daily, especially in the field of law enforcement when it comes to dealing with COVID-19. So some of the other things that we've discovered is the impacts of $0 bail. This was instituted by the Judicial Council and requires $0 bail based on the charges that the person was arrested for, and it applies to no bail warrant arrests as well. Within Sacramento County, some of you may know or may be aware that we have a serial inebriate program, or SIP as we like to call it. Bail is not applicable in these violations without judicial review. These folks, where they would normally be taken into custody and be required to stay in custody for a specified amount of time, they'd be released, they'd be sobered and released from our facilities. Another one that we have here in Sacramento County is the chronic nuisance offender program. Bail is not acceptable or applicable for these without judicial review as well. Again, these folks are also sobered and released without the custody requirement. So we're releasing these folks back into the community without either providing them treatment or being able to keep them into custody where they would normally be out reoffending in the community. This pretty much concludes what we've prepared for you folks today. I know there may be several questions about the jail, and I may be able to answer some of those for you, but this concludes our presentation today. And I again, thank you folks for letting the Sheriff's Office play a part in it and provide you some information regarding our facilities.
Thank you, Sean. Yeah, it's really good information. And we have been leaning heavily upon the jail as a sobriety center, and it's really not the right place to do it. Next, we'll have Brian Jensen from the Hospital Association and Rosemary Youngs from Dignity Health to talk about impacts to hospital EIRs, and then especially the need to reduce bringing people who are intoxicated to the hospitals during the COVID crisis. Whenever you're ready.
Great, thank you. Is everyone able to hear me all right?
Yeah, we've got you.
I'm Brian Jensen with the Hospital Council of Northern and Central California, and we are an association that consists of all the hospitals and health systems. We work throughout Sacramento County and beyond, and a lot of what we do is to convene healthcare leaders and other stakeholders around many of the issues that we're talking about today. So I wanted to just give you a little bit of a high-level view from the perspective of hospitals about some of the issues that we're wrestling with here, and which the SURE program is designed to address. And then Rosemary from Dignity will talk a little bit more specifically with some data about some of the specific facilities and what those impacts are. But I'll say that for the last 4 years, behavioral health has been the #1 concern for hospital leaders throughout the state of California. In the surveys we do of our members, it has just shot to the top over the last few years. And it's something that plays out in a whole host of ways. There are great challenges associated both with mental health and substance use disorders. And I think it plays out most readily in the emergency departments, and we'll talk a little bit about that as people are brought in or come in either by law enforcement or in other means because of those needs. I'll say also that homelessness over the last few years has been an alarming trend that hospitals have wrestled with as well. And the situation plays out in hospitals in a lot of problematic ways, very challenging ways, trying to address basically deep-seated social issues that are in a setting that's designed for healthcare. And so it's not always the right fit either. And then lastly, I'll just say that obviously the current pandemic, COVID-19, is the preeminent concern over everything that we're dealing with and affects all of our operations. I will say that the SURE program is a key component to addressing each of these 3 challenges: behavioral health, homelessness, and the spread of COVID-19. And so I think could be a timelier approach to addressing these very challenging topics and issues. We do a lot of convening around these issues with emergency services. And so we have regular tables at which law enforcement, EMS, ambulance providers, county behavioral health, all the hospitals are all sitting together trying to wrestle with solutions for, we have problems that are trying to be addressed by a system not designed specifically for those problems. What is so encouraging about SURE is that this is a solution tailor fit to the problems of substance use disorder and addiction. So that, similar to not trying to solve it through a law enforcement mechanism, also not trying to solve it by transporting someone to the emergency department when that may not be the kind of care that they need at the moment. If they have other medical emergencies as well, obviously there's a role for hospitals. But when you're talking about a serial inebriate, a meth addict, you're talking about even sometimes one-time inebriates that don't exercise the best judgment and put themselves in a compromising position, the ED is not necessarily where they need to go. Having a center like the SURE Engagement Center would just be fantastic. We are wrestling already, pre-COVID-19, hospitals were already wrestling with tremendous strains on our emergency medical services system. That goes from the pre-hospital setting, so the city's fire department with its ambulances, as well as law enforcement addressing issues that are somewhat healthcare related as well, or in social service related when we're talking about people with both mental health and substance abuse challenges. These were already issues that were straining our system, making it difficult to promptly offload patients from ambulances into the emergency departments because they're so crowded at the time. And a lot of the volume of people that we're encountering are people that are there because there's no better place to be, but they're not there because that's the best place for them. It's not really designed for them. And so I think the hospitals in the region would be very, very supportive and are very supportive of SURE. And WellSpace is a trusted partner who's done great work in a host of areas already and works closely with each of the health systems. And I think this fits brilliantly into the continuum of care already in place with WellSpace and the broader healthcare community. And what this will do is give us a key service that's missing, frankly. There's not a place for people to be taken where they can both sober up, but also be connected to key essential services and supports that they need outside of a jail, outside of a hospital, but in a place where they need it in a way that they need it. And obviously we've heard from some experts in the field today that can bring to bear the cutting edge approaches to addressing these challenges. And so I just want to share that from the high level, this is something that's been missing. It's something that for years we've talked about in different ways, but it's great to have a tangible, concrete way to approach it now. And it's something that is sorely needed. And with that, I think I'll turn to Rosemary Yance to give us more detail from some of the specific facilities.
Hi, good afternoon, Mayor Steinberg, Vice Mayor Harris, and members of the council. Let me get my couple of slides up here. Are you all able to see? Great. So our group has been working on gathering data, and we still don't have all of it from the health systems, but I do have Dignity Health data from our hospitals that I'd like to share. And I think it's safe to say that it's very similar, give or take a few, to what the other health systems in the region are experiencing. I'm showing alcohol first. I did include alcohol because it, along with methamphetamine, is a major problem that we see in our community and in our hospitals. The data you see is over a past 12 months. And this is for cases that we call uncomplicated, meaning there is no medical care required when they come to our emergency departments. And these are the cases approaching 2,000 that would be very, very appropriate for a SURE program. I'm going to go right on to methamphetamine because that is the major topic of our discussion here. This chart specific to methamphetamine again shows cases in our hospitals over a past 12-month period. There is quite a significant or a higher level of medical complications when it comes to methamphetamine. So what I did here was separate out the medical from the non-medical. So it's the number of uncomplicated visits, about 343, that would be appropriate today for the SURE project. I do want to note, though, that these numbers for methamphetamine represent just a tiny segment of the population we see in our emergency departments that use methamphetamine. These numbers here reflect only methamphetamine as a chief complaint or a primary complaint or condition when individuals present to the emergency departments. What's not reflected here is literally the hundreds of individuals who come to us with a different medical complaint, but through the course of lab work, tox screens, and treatment, we see the presence of methamphetamine in their systems. That's not a good sign for where they could go in the future and where these numbers could go in the future. I will say when it actually getting very good at treating addiction, opioid addiction, through training and medication assisted treatment through the use of substance use navigators. And we've had quite a bit of success when it comes to opioids, but we are lacking, sorely lacking, when it comes to how we approach and treat methamphetamine in our hospitals, in our emergency departments. So some of the training that SAMHSA was talking about early might come in very, very handy. As Brian mentioned, you know, this challenge is not new for us. It's been with us for quite some time, but today it's a much bigger problem in the middle of a pandemic. Our emergency departments are quickly becoming overwhelmed. If we did not have a large surge before, we are certainly experiencing one now. And so trying to manage this population during the crisis, the COVID crisis, is making it a much more difficult situation. Folks that come to us are brought to us by law enforcement or other who are under the influence of a substance or alcohol, methamphetamine. They are occupying beds for long periods of time to metabolize before we're able to discharge. They're requiring additional staff and resources that are pretty precious to us right now. There's also an increased risk of COVID-19 exposure. We are a high-risk environment, and folks that are under the influence are not able to social distance or follow any of the safety protocols that we have in place. And I'll be brief, that is all I have, unless there are questions, and happy to answer. Thank you.
Any questions for Brian or Rosemary at this point?
I have a question for Rosemary, Jeff.
Go ahead, Larry.
Rosemary, are people leaving the hospital against medical advice a big issue?
You know, we do have quite a few leaving against medical advice, quite a few that actually attempt to elope. Is an issue. I would, when you look at the total cases, is it a major that do want to leave and do leave against medical advice or elope when we don't want them to leave? Yeah, there are definitely cases. And it's very hard in an emergency department environment to convince a person to go into some type of treatment. They don't like being there. They just want to leave.
Would you envision the same thing would be true in a SURE environment?
You know, I don't. I think it would be a much different environment. They would have fellow people there that obviously are experiencing the same thing. They have resources readily available. As you know, WellSpace has kind of the continuum of care, and Sacramento County has care they can offer. They can capture individuals at the point of contact there, whereas in an emergency department, you know, we're always kind of fast-paced and busy. So I think just having them in that different environment would make a very big difference.
And having people trained to deal with their specific issues.
Yeah, absolutely.
Okay, thank you.
Thank you, Larry. Appreciate that. Well, we're coming down close to the end here. We'd like to bring up Lori Miller, who is really kind of the resident expert about meth and addiction at the county. I'd also like to tell the council members that this group, absent the first two presenters, has been meeting every week for quite a while to discuss all of these issues in depth and shape the idea of the SURE program and talk about how to actually physically enable it and get it out of the ground. So I have a deep debt of gratitude to all of these amazingly smart and talented people. They are really creating this program for us. So Lori, if you're available.
I'm not sure if everybody can see me.
We can see you.
All right, great. Good afternoon, Mayor Steinberg and Vice Mayor Harris and City Council members. My name is Lori Miller. I'm the Division Manager for Sacramento County Substance Use Prevention and Treatment Services. And I just want to say thank you so much for the opportunity to come before you this afternoon and really talk about many of the things that Sacramento County is doing to address this meth issue that's devastating individuals and families in our community. I'm really proud of what we have accomplished at the county level, but there's certainly so much more that we need to do to address this issue. So just like with opioids, there's way too many people that are overdosing, way too many people that are dying due to meth and polysubstance use here in the Sacramento region. And these people have faces, they have names, they have families, you know, and they need our help. And so I want people to know that there is help available, although we could benefit from additional resources and services, especially to take the burden certainly off our law enforcement and emergency departments. So before I get to my PowerPoint presentation, I just wanted to acknowledge a few people. I wanted to first acknowledge my county leadership, Dr. Bielenson, who is our health director, and Dr. Quist, who is our behavioral health director. I want to thank Supervisor Cerna and acknowledge his valiant fight, advocacy, and support to address meth use here in Sacramento for many years. I want to acknowledge our partnership with the City of Sacramento and thank you, Mayor Steinberg and Vice Mayor Harris for making this a priority and for your leadership, for your commitment to these needed resources and services in this area addressing methamphetamines. And lastly, I'm so grateful to our law enforcement partners, our hospital and emergency department staff, our community-based providers, and other departments and stakeholders for their tireless efforts in the trenches to combat this public health crisis. And it truly is a public health crisis. So I'm going to go ahead and start my screen share here for you. Okay, so let's talk about meth in Sacramento. And what is the scope of the problem? You know, meth has been around for quite some time. It's been around for years. Unfortunately, it has been overshadowed, as you know, by marijuana and opioids in our community. But meth abuse is certainly a threat and devastating our Sacramento communities. It is a community disease. As you all know, it's very cheap and easy to get, and we've heard the high potential for widespread misuse. And we've also heard how it's impacting all of our service systems here in Sacramento, from child welfare to criminal justice, to our health systems, to behavioral health, and to law enforcement. And with COVID being an emerging health threat, we've learned the following. We've learned research from NIDA, which is the National Institute of Drug Abuse, and they suggest that COVID-19 could hit some populations with substance use disorders particularly hard. And people who use meth may be more vulnerable to the drug's effect on respiratory and other pulmonary health. Individuals with a substance use disorder are more likely to experience homelessness or incarceration, which poses unique challenges regarding the transmission of COVID-19. And due to COVID-19, people are experiencing increased fear, anxiety, depression, social isolation, and suicidality, among unemployment and other issues, and this causes, of course, increased risk of substance misuse and infection. So let's look at some of the characteristics of individuals who use meth in Sacramento County. So according to our data, people abusing meth are more likely to be between the ages of 25 and 39, Caucasian, female, suffer cognitive impairment during early weeks and months of recovery, be at risk for heart disease, be at risk for non-injection transmission of HIV, be at risk for syphilis, and be victims, especially women and or perpetrators of violence, and also be at risk of homelessness in our community. So here, you know, so what are the available treatment resources in Sacramento? So this slide kind of speaks to our continuum of care for fiscal year 2021 and what we offer with regard to all substance use disorders, from prevention services to services of various modalities of care, programs, and other types of services specific to maybe the perinatal population or the criminal justice population. And this slide shows treatment or service types that we use specific for methamphetamine. So we have outpatient treatment, we have intensive outpatient treatment, residential treatment, detoxification or withdrawal management, sober living environments, recovery residences, and other services like case management and recovery support or aftercare services. And as we heard earlier, there are no FDA-approved medications currently for methamphetamine. On the right side of this slide, it speaks to certain access points across the Sacramento County region for a person who may come to our system for a substance use assessment or referral to a different level of care. So we have counselors stationed at a variety of different places throughout Sacramento. Our system of care where people come primarily to receive a substance use disorder assessment and referral. We have counselors stationed at our Sacramento County main jail and our Rio Consumers Correctional Center, our probation department, Sacramento County Health Center, our guest house homeless clinic, our juvenile court and youth detention facility, and at our contracted provider sites. And these are service definitions. So, you know, what does treatment look like with regard to these modalities of care, the length of stay, and the types of services that a person may receive if they go into treatment. And each of these services include an intake and assessment for a substance use disorder, an individualized treatment plan, and discharge planning to coordinate continued services. Okay. So this is a slide that speaks to the primary substance use data for fiscal year 18-19, and it's very close to data in terms of fiscal year 19-20. So if you look at the number of people entering our system, the first box on the left, we have about 5,000 people entering our system for all modalities of care. And so meth is the #1 drug of choice in Sacramento, but this data is a little bit misleading because for methamphetamine, people cannot get medication-assisted treatment like they can for opioids. So when you look at the 5,000 people, if you take out the medication-assisted treatment and look at the middle box for people who would enter our system and receive these types of treatment services, detox, outpatient, or residential care, you're looking at about 3,400 people. So the primary drug of choice here in Sacramento is truly methamphetamine at 37%. The other drugs that are listed that on the bottom there at the 6%, I just kind of wanted to call those out for people if you're interested in knowing what other drugs were captured. Those would be barbiturates, cocaine, ecstasy, sedatives, other stimulants, and over-the-counter medication. And this slide captures our system partnerships, who we value and appreciate very much. So we have partnerships with all of these service systems in Sacramento, of course, our criminal justice and court systems, law enforcement, child protective services, hospital systems, primary health and correctional health, public health, and UC Davis Medical Center. And we work with these partners on an ongoing basis with various programs and services that we offer at the county level. We provide education, training, we provide assistance to help people access care and navigate our system. We work with our partners around case management and within collaborative court programs or other types of services, as you can see indicated there in that slide. And again, a little bit more data for you, this pre and current COVID-19 data. I wanted to add some information specific to COVID. So we collected some data from March of 2019 to May of 2019. And of course, we saw kind of COVID emerge in March of 2020. And so due to COVID-19, there was an overall reduction of substance use services across the board, as you see, from last year to this year. About a 20% reduction in opioid use and about a 40% reduction in people entering our system for methamphetamine. And I think there's a number of different reasons why we see that. We know that there's no shortage of people using substances during this, most difficult and challenging time right now. But these are people that are not currently entering our service system that probably would have before. So some of these factors might be due to the fact that meth is typically mandated through court or CPS involved clients. So people who use meth are typically mandated into treatment versus people who use opioids may not be mandated into treatment, and they are using medication assisted treatment in order to assist with that area. Another issue may be because the courts were closed for quite some time and recently reopened, and we were also not able to do some assessing within the Sacramento County Jail for a month or so. And I think that decreased some of the numbers that we are not seeing right now due to COVID. And again, as you know, there just is not any medication-assisted treatment available for methamphetamine right now. And we're hoping with the research that's currently underway and some of the information we heard from our SAMHSA partners and experts that maybe there's some hope around that area moving forward. And if you can look on the bottom of this particular slide, we did see a slight increase in the other drug use from 5% to 12% within those time frames. And again, those drugs were including barbiturates, cocaine, ecstasy, hallucinogens, and over-the-counter medications. Okay, so I wanted to also highlight our accomplishments and some of the areas that we have been focusing on with regard to methamphetamine. We began this effort back in 2015. So the next couple of slides are going to be covering the county highlights and accomplishments in addressing meth. So we have done quite a bit of work around this area, but as you've heard from all of our experts here this afternoon, that there's certainly more work to be done in this area. So in 2015, we were tasked with developing a plan to strategically address meth use in Sacramento by our Board of Supervisors. And Supervisor Cerna was a strong advocate and continues to be a strong advocate in this area. We completed in 2016 our meth strategic plan, as well as our initial report that was presented to our Board of Supervisors. And then between the years of 2016 and 19, we did a series of trainings to our hospital systems, a lot of our community partners and stakeholder groups, just around methamphetamine use and the impact to our community, how people can access care, and those types of things. We also were able to procure additional funding to expand residential treatment, detox, and sober living services to address methamphetamine, and additional funding to expand services for our early intervention family drug court. And a lot of the people that enter these types of collaborative courts, this one in particular, are pregnant and parenting women that are also involved in the Child Protective Services system. And a lot of times, oftentimes, we see that meth is the primary drug of choice with this particular population. We also procured additional funding for increased drug testing services for our providers as part of the treatment planning. And then in 2017, we held our first meth symposium to educate all of our stakeholders around meth and what it looked like here in Sacramento with about 140 attendees. All right, in 2018, we were able to streamline our assessment process at our main system of care, where people, what is called the point of entry into our service system, as well as our jail settings, in order to have faster linkage for people to get into our system of care. We held a meth awareness campaign, our first awareness campaign in Sacramento, in some high-risk areas around the area that I'll talk about on the next slide. We launched a substance use disorder anti-stigma campaign, and we held our first meth public forum to educate the community with 120 attendees. So in 2019 is when we actually launched our meth coalition, and Supervisor Cerna again provided opening remarks at this community public forum in 2018 at the initial meth public forum, and as well as at the initial meth coalition meeting. We also began county social media messaging and posts around the meth coalition, trying to educate our community about this coalition, and tried to talk to all of our stakeholder groups and partners about the importance of addressing this issue. We also received increased perinatal residential treatment beds from 16 to 26. And again, I spoke to this population of pregnant and parenting moms that is pretty high population here in Sacramento, involved in our Child Protective Service system, whose primary drug of choice is meth. And then lastly, in 2019, which was the most exciting event that happened for us in the substance use treatment area of the county, is that we received increased funding to implement what is called the Drug Medi-Cal Organized Delivery System waiver. And what this waiver did was be able to offer and fund all modalities of treatment and expand service capacity here in Sacramento so that more people can get into care and get into care more quickly. So some of the goals of the waiver basically were to improve our current substance use disorder service delivery system through creating a more organized system, being able to offer a full continuum of care with multiple service levels with evidence-based practices. We were able to increase program oversight, compliance, and quality assurance, and improve coordination with other service systems, particularly the criminal justice system and our hospital systems. And then in 2020, we continued to convene our meth coalition. It has over 100 members currently. We will be developing the second meth outreach social media campaign called Let's Talk Meth, and I have a slide that I'll talk about that. And then lastly, we're exploring other meth interventions like this substance use respite and engagement center that you're going to hear more about in the next presentation.
Lori, we're
Yes.
actually running up against the clock here. The City Council has a closed session at 4. I'm wondering if you can sort of speed it up and get to the end so that Jonathan can present about the SURE program.
Sure. So this slide just speaks to our coalition and the meetings that we've had and the impacts of the different service system and subcommittees. Anybody interested in our next meeting is August 13th, Impact to Child Welfare. This was a little bit of information on our first awareness campaign, but I wanted to get to our current methamphetamine outreach campaign that began in 2019, and we plan to launch it in 2020. And there's a little bit of information about that. So I just wanted to say in closing that addressing this meth issue in our community is really a great effort, and it's going to take all of us in a great partnership. And it's one that the county is certainly proud to be a part of. It's important work, and we all have a shared objective in keeping our community safe. I especially want to thank WellSpace Health, and I know that you're going to hear from WellSpace for their continued partnership in developing this SURE program. So thank you, all of you, for recognizing this problem, listening, and wanting to take action. It's truly an exciting time for all of us for change, innovation, and solutions. So thank you so much for listening.
Thank you, Lori. I appreciate your time and your presentation and your continued work in this space. So that brings us to what we want to tell you about, which is the SURE program proposal. So Jonathan, you want to launch right into that?
Yes, thank you. Or should I say, sure. You know, if I can't do a better job of explaining how much partnership there is in this community than the people you've just heard from. And so it is, it's truly a collaborative, as you could hear. We have wonderful partnerships. We've tried many different strategies for many different things in this community through all these partnerships. We have terrific leadership from city, from the mayor, from all of you on the council, from Phil Son and other supervisors at the county. So it empowers us. And the empowerment we had here was to develop the Substance Use, Respite, and Engagement Program, which we're calling SURE as an acronym. Really important, the word engagement. This is a substance use, respite, and engagement program to provide short-term, which is literally 4 to 12 hours, recovery, detox, and recuperation from the effects of acute alcohol or drug intoxication. The SURE program will be staffed 24/7 with healthcare professionals, as Councilman Carr mentioned, people who are trained for this, to provide medical monitoring, substance use disorder counseling, and connections to support services upon request. And the clients will be transported to and from the SURE facility directly by authorized referral partners and will have no walk-in option. We will serve all folks. We will be focusing on alcohol, methamphetamine, and opiates. And as you can see, the highest drug of abuse that we will encounter is methamphetamine. If we were to run this according to the 24/7 model and the 4 to 12 hour time period, we could manage just under 22,000 people a year in the 10 rooms by providing 2 people per room with a 6 to 12 hour average length of stay. Given COVID, we're being very careful about having a kind of a structurally safe place for people. Because we want to make sure that we don't have a large open plan care for people while we're under this pandemic. The 24-hour services will be medically monitored. People will have a bed or a reclining chair. We've kind of looked at different models and they use both. Clients will receive water, light snacks, a shower and a bathroom, and importantly, substance use disorder counseling, case management, and peer support. These are all going to be evidence-based interventions. And again, the SAMHSA, ISAP have developed models for all of these things that are science-based, and we've adopted them in many of our programs, and they're integrated into the SURE program. And importantly, services will include transportation home. The care team will be made up of a substance use disorder counselor, a nurse, a medical provider, and a case manager. Again, as Councilman Carr mentioned, and when Ms. Yance was talking about the hospitals, we're talking about people who are trained for this. There will be a program manager, an assistant, administrative assistant, a transportation technician, which I believe means driver, and a maintenance technician, because this is a high turnover, high volume environment. The care team will have a 24-hour staff of licensed vocational nurses, certified drug substance use disorder counselors, case managers, and peer support. And literally, there are certifications for people who with lived experience who have been certified in case management, who can kind of evangelize the movement into treatment. And that's why the engagement part of SURE is so strong. There'll be the administrative assistant and the technician and the driver as well, and a program manager. We have an aggressive timeline. We are trying to get this thing going, essentially to bring the benefit of it as quickly as possible to reduce the transmission of COVID and reduce the likelihood that our potential clients could be vectors or could be infected by COVID. So in July, we plan on staff recruitment and minor tenant improvements in the service site in District 3. So we have a central site that we would start in. And then we would commission the site in September and start onboarding the staff by mid-September and start the program no later than October 1st. With the end of this program period, because of the way the city COVID program is structured, would be December 31st. So we would have a report out to stakeholders by the middle of January 2021. Generally, the impact is 60 people a day. We avoid jails and emergency departments, and we connect clients to substance use disorder treatment services. This is a reorientation from moving people from one place to another and really moving people towards care and really focusing on that engagement and providing the appropriate people to reinforce the need for care and the need for treatment with the people we serve. That is the SURE program, and I'm open for questions.
I have a question.
Questions? Yeah, Jay.
Jonathan, thanks. And Jeff, thanks for all your work on this. I appreciate that. And no question in my mind that the services are necessary if we're ever going to get on top of some of the challenges that we have. I guess the financial question for me is, do you guys have a financial pro forma on this? What happens after the COVID money runs out? How is this sustained? I mean, I know we're kind of turning the city into a social service agency. There's pluses and minuses of doing that, but on the financial side, I'm just wondering.
So, Jonathan, maybe you can talk about the federal approach there.
Yeah, definitely. We are looking at the possibility of other federal funding coming down that would support continuity of these services. And we also know that we need a proof of concept in the community. This is a very strong program, and this would get that ball rolling. And we know that some of our partners in the community really need to see this start to continue it. We're pretty confident that between continued federal support and evangelizing this program in the community by running it, we will be able to create continuity. Down the road, with the waiver that Laurie Miller mentioned, it's quite possible, and with CalAIM, the way that the state itself is looking at restructuring behavioral health services through the Department of Healthcare Services, this kind of concept is actually being considered for direct funding through the 1115 waiver that DHCS is managing. So again, proof of concept is required. So this is it.
So at this point, there's no assumption of ongoing funding from the city?
I'm not in a position to
Maybe that's a question for my colleague from District 3.
Yeah, your colleague from District 3 would say, we're using CARES Act money. I see Mayor Steinberg has something to say as well. We're using CARES Act money to start this program and show proof of concept. But as far as city money moving forward, I am not anticipating that we're going to have very much to use for that. Once we have proof of concept, I do believe that hospital associations will see the value of this, and they can be a source of funding. But maybe Mayor Steinberg would like to have a few words.
Well, I think there's a couple of things. Thank you, Vice Mayor. Number one, in the midst of a very difficult time, the news keeps getting better when it comes to homeless related funding. The state, for example, just put out its NOFA for the State CARES Act money, which we initially, this is the 600 million, we initially anticipated that that was all going to be competitive and we would compete, no doubt about it. But instead they have broken it down, at least in its initial phases, through regions. And our region, which of course is more than the city of Sacramento, but it's certainly where the lion's share of the work is, would be about $27 million. So that's on top of all the other resources that we're compiling and that we're going to talk about next week. And so we have the ability to not just do proof of concept, but to sustain the proof of concept for at least a reasonably long period of time. And then we have to enter into a formal collaboration with the county. There's no question about it, because the county is the health and human services provider, and Phil Cerna, as we have acknowledged, put a ton of leadership into this. And so because we seem to have more flexibility on the care side, and Jeff Harris has stepped up in the way he has, we now are just sort of taking the temporary lead. But in the end, it's got to be a partnership. Finally, I think Bridget Dean's testimony is very important, because as we establish and grow this Office of Community Response, whatever we're going to call it, this idea, as she alluded to, I think is a big piece of what it is we want to do. And so I'm confident we find the money to do the right things. And I'm confident that we'll find the money to be able to not only launch this, but to sustain it. And then if it's successful, which I believe it will be, we'll always find a way.
Thank you, Mayor. I couldn't agree with you more. I think that quite likely we're going to find out that our capacity will be exceeded pretty quickly, because there's such a huge community need for a center like this. Time will tell, but sometimes, Jay, you have to take a leap of faith. There are so many great experts in our area indicating that we need this facility, as well as law enforcement and medical professionals and ERs. I just think that, you know, once we start, we're going to find that the ship floats very, very well. I see Councilmember Guerra has a comment.
Thank you, Vice Mayor. Actually, the Councilmember Chenier asked my question, but I will just say that one, thank you for your leadership on this and for bringing this forward. And I think it was acknowledged earlier also, thanks to Supervisor Cerna for also doing the long haul here for a long time and keeping this moving forward. And I think it's going to be that county and city collaboration. And I'll go back to one of the comments that was brought up earlier by one of the presenters, and that's if we expect that only the penal code or the criminal justice response is the solution to our meth crisis. If we're expecting that to be our solution, we're just going to see what we've seen now only grow and continue. And if anyone has ever had a family member who is suffering an addiction and has had to deal with the demons that are within them, I think they would know, and folks would know that it's a false expectation, particularly with someone who's suffering from meth addiction, that they're going to get out of it on their own. And I think this is a great opportunity for the city to show proof of concept for the state on a new proposal. And so I commend you, Vice Mayor Harris, on this effort, and for all the partners involved in this.
Thank you, Councilmember Guerra. We do have a couple of callers online. You know, council members, you've been very patient. We've brought you an awful lot of information, and I really appreciate your attention, because this is a very important topic. Let's just, we have 4 calls. Let's move through those, and then we'll curtail this and move to our closed session.
Thank you. First caller, please. Welcome to the meeting. You have 2 minutes to address the council.
Hi, good afternoon. My name is Bernice Jimenez Krieger. I am a resident of Woodlake in District 2. I want to thank Councilmember Harris for this discussion. Mass addiction is a real problem in the homeless community, and as SURE program funds are used to obtain a facility, I am urging the City Council to please follow Supervisor Cerna and the Director Edwards' recommendation to not consider the Shore Stay or the Evergreen facility for this program. As Harris said, we want to ensure this is a public health crisis and does not form into a criminal crisis. As Dr. Free stated, meth is worse than anybody else thinks, and it's really, really bad in our area. We have had incidents, unfortunately, of Shore Stay residents that have committed crimes. Most recently, a lady bearing a hatchet that tried to break into a neighbor's yard and injured an officer. Also, as Dr. Petraeus' slide showed, the facilities that are available for services are not anywhere near our area. There's no treatment facilities nearby. And that is a huge disservice to the homeless individual as well as residents of this. So again, as you guys are considering using this funds, we want to partner with you. Members of the community are here to help out and to try to see what are some of the things that worked well, what are some things that didn't work so well, and to please urge you to follow again Supervisor Cerna and Director Edwards' suggestion that they said at the last board meeting about why this particular location was not recommended as a permanent facility and why it shouldn't be in a residential area. So again, Councilmember Harris, thank you for this conversation. Councilmember Warren, hopefully we can work with you to work with the other members to show why this is not a good place for this, so that we are again not pitting the interests of homeless individuals and the interests of residents against each other. We all need to be working collaboratively on this. Thank you.
Thank you for your comments. Next caller, please. Welcome to the meeting. You have 2 minutes to address the council.
Yes, as a concerned citizen, I would like to remind people about the devastation of crack and how that resembles this type of drug usage, but there was not the same compassion and outreach to people of color who ended up in prisons and devastated families and long prison sentences. So as I look at this, I wonder, where was that compassion in all of the different services that are available? Now, I did notice on the graph that the #1 user of methamphetamines and opiates are Caucasian. So maybe that's the reason why there's such an outpouring. And I never remember no dollar bails for crack addicts. And as a matter of fact, they were mocked and they were even called immoral. And now it's more of, it's a disease. So I want, while the hearts are tender today, I want all of the mayor, the vice mayor, the city council to remember that. That wasn't that far ago. And I know personally that this is what was needed during crack. But now there's so much tenderness towards methamphetamine and opiates. And it's because opiates users' babies are now being addicted to opiates and methamphetamine, just like crack babies came out of that. So I want you to keep that in mind as you spend a lot of money for this type of behavior, which was definitely not called immoral.
Thank you for your comments. Your time is complete. Will you make your final comment, please?
So just remember that. Thank you.
Thank you for your comments. Next
we got
caller,
it.
please. I have 2 more callers. Next caller, please. Welcome to the meeting. You have 2 minutes to address the council.
Thank you very much. Honorable Steinberg, Harris, and the rest of the City Council, thank you for your time. My name is Stacy Leung Crawford, and I am a resident of Woodlake, and I am a former community college educator and currently a nationally board certified health and wellness coach. And I'm calling to show support for the SURE program. I believe in drug and alcohol rehab, mental health care, physical care, everything else, job skills, etc. However, I have been impacted pretty severely. I'm not even normally a scaredy cat, but I live directly adjacent to the Sure Stay Hotel, which has been funded through Project Roomkey and managed by the Goodwill program. But we've had multiple incidences of violence in the neighborhood, including 3 fires. And on Mother's Day, a little before 8 in that morning, I had to call into the hotel who was not aware of the property damage that was going on in our backyard. It ended up being a woman on meth who used a hatchet and broke through my neighbor's fence, just literally 20 feet from my own house. My neighbor was afraid for her life. Her wife was away at the store. Police officers finally arrived. They arrested the woman who hurt one of the officers' wrists. It was completely traumatizing. So while I support the SURE program, even though I don't know much yet about it, but I heard the former speakers and I did join in late, I cannot have this in a residential neighborhood where it is also endangering my neighbors, myself, my family's lives, and causing complete disorderly chaos. Now, if you are thinking of defunding police,
Thank you for your comments. Your time is complete. Will you make your final comment, please?
yes. So, City Council and Mayor Steinberg, please reconsider where you are placing this type of program. I implore you to consider us, the residents. Thank you.
Thank you for your comments. Next caller, please. Welcome to the meeting. You have 2 minutes to address the council.
Hi, thank you. My name is Stuart Gow. I'm a resident of Woodlake. I also would like to thank Councilmember Harris for bringing this discussion up. I'm specifically calling to talk about meth-related crimes that Project Roomkey at the Sure Stay Hotel has unfortunately brought into our neighborhood. Hearing this discussion, I'm quite shocked and disturbed that that Sure Stay was chosen as the location, knowing these dangers. I personally know of some serious incidents. Bernice Krieger referenced a hatchet attack, which was a neighbor who shares a fence with the Sure Stay Hotel, and her fence was broken in by a hatchet, and police were involved. Another neighbor also in Southgate had a nighttime incident with a woman on meth trying to break in her front door, and again, police and fire department had to be called to deal with that. We've also had a neighbor who was seriously injured and her dog very seriously, if not, it was a mortal injury perhaps, we don't know, at the police memorial by people who are suspected of selling meth to residents of the Sure Stay Hotel. I personally live on Woodlake Park, and on a daily basis I see Sure Stay residents. They're identifiable by their lanyards, smoking out of aluminum, what looks like aluminum improvised pipes, with various people coming back and forth and meeting them. And also there's no social distancing or masks observed by these residents. I know that the county has stated that they are.
Thank you for your comments. Your time is complete. Will you make your final comment, please?
Sure. I just think that low barrier homeless programs like this should not be near anybody's residences, near no family homes. Thank you very much for letting me speak.
Thank you for your comments. Vice Mayor, I have no more callers.
Thank you, Mindy. Larry, did you have a comment?
I do have a couple of questions. One for Lori Miller, if she's still here. I see her signed on. Lori, is the county looking at taking over this program? And why isn't the county doing this?
The county's not interested in taking over the program, but continuing to partner with the program. And I know that the county wholeheartedly supports the program. As you've heard, we've been working on methamphetamine for many years with the support of our Sacramento County Board of Supervisors. I know that the city took the lead with this proposal right now, and I know that there are discussions happening at the county level in order to sustain this program and look at additional funding moving forward. And as Jonathan mentioned earlier, and I spoke about the drug Medi-Cal waiver, which is an opportunity to possibly fund or expand services in the future. And of course, with Tom Freese's presentation from SAMHSA at the county level, we're certainly going to be looking at any funding we can get. And now that there's more emphasis on methamphetamines and not just opioids across the local level, state level, and federal levels, I will certainly be looking into that funding as well moving forward to expand this great opportunity.
Well, I think to all of us, a program like SURE makes sense. But if it makes sense for Sacramento, it should make sense for Elk Grove. It should make sense for Citrus Heights. It should make sense for the unincorporated area, and that means county.
Absolutely. It does make sense to us. And I know that my county leadership is looking into what they can do to assist the city and funding this effort moving forward.
Well, I appreciate the assistance, but it seems like to me this is a county function. We should be assisting you.
I understand your concern, Councilman, and I will certainly take that back to my leadership.
Second question, Lori. From everything I've seen, the coronavirus is not running rampant amongst the homeless population. The spikes that we are seeing, according to what I've been seeing, are coming from house parties where people are getting together to celebrate graduations, anniversaries, and the like. Is that what you're seeing as well?
Yeah, I think that I'm not the best person to speak to, what's happening across Sacramento in that respect. I think that our health director, Dr. Billinson, is probably the best person. I know that he has spoken to the fact that we are seeing it in the homeless population to some degree, but a small degree. But again, that's probably not the area of my expertise to be speaking to that.
Okay. Yeah, a couple of the speakers talked about the coronavirus being a problem for the homeless population, and I'm sure it is to some extent, but it doesn't seem to me to be the major problem. And I do recognize what one caller said about the treatment of people who were convicted of possessing crack versus the treatment of people who are abusing prescription drugs. Society does treat them differently, and it's just one of the inequalities that we've seen in our society for generations and generations. Jeff, I think it's a good program. I can support it as a pilot. I think we have to find ways to fund it going forward, as well as bring all of the other jurisdictions within the county, if not the county, along with us. So I'm willing to go for the $1 million to have this thing kick off as a pilot. It's needed. I think the hospitals will support it along the way, and perhaps we'll get other funding for it. But since we don't have core competence in this area, this is something that we should be really looking to pass off to the responsible jurisdiction. And thanks for putting it together, Jeff.
You're welcome, Larry. And actually, I agree with all of your comments. The idea is to do proof of concept. If it truly is going to fill the need that all of the experts think that it will, then other jurisdictions will be looking for the same kind of respite. And I believe that we'll find the resources and probably, hopefully, at some point, transfer it to the jurisdiction that really covers these issues as a matter of course. Anything else from the council? This was a discussion item.
Jeff,
that asking, oh,
Vice
go ahead.
Mayor? Yeah, this is
Alan?
Yeah, this is Councilman Warren. Thank you. And I want to thank you as well for bringing this project forward. But I too, like Councilman Carr, have concerns about equity and how facilities that treat things like drug addiction and homelessness are continually placed in the underserved communities, and sometimes with little or no notice. And so, and I don't want to appear to be ganging up on Lori or the county, but I do think it's appropriate that we ask questions of the county. I think it's also appropriate that we expect them to live up to the responsibility that the county should have and at least share with the city, if not take the lead. And so I would, do we have, Jeff, have you had discussions with anyone at the county that have talked about how do we start to get some efficiency and continuity with collaboration with the city, or maybe with us supporting them as opposed to us coming up with programs and then trying to shoehorn it in and make it fit with the county's program?
Well, council member, throughout the entire process of building this program, county staff have been at all the meetings. And yes, the subject has come up, and this is not normally the purview of the city. And I tend to agree with you, and we have tackled that issue. But the reason that county staff has been involved is because they recognize the need as well. Dr. Bielenson has attended many of the meetings as well. And I have every confidence that as soon as we show this proof of concept, that the county will understand how vital it is. And we'll see where that will lead us. At this particular juncture, the county is dealing with the homeless issue through Operation Room Key and the motel project. They've got a lot on their plate, and they were not in a position to take this on at this time. But WellSpace stepped up, and so this is the program we've created. But understand that there already is county collaboration, and has been since we first started talking about this process, principally through Dr. Bielenson. So I can't prognosticate exactly what the county will do moving forward, but I would say this, it's well supported by staff. And I have been talking to county leadership about the program as well, and garnering support.
Okay, well, I would just encourage, I think having county staff at the table is fine, but ultimately the decisions will be made by the electeds. And it'd be nice to have some leadership coming out of the county as well from the elected office that can help give direction to county. So, but I want to commend you for your good work. And I know that this is not easy. However, this is a big issue to tackle. And, I think collaboration and supporting one another, maybe this is a good opportunity for the city and the county to really decide that we're going to make this a priority and get it dealt with. So thank you very much.
Actually, Councilmember Warren, that's the reason I tackled it. I think we all recognize that there are many issues that are cross-jurisdictional, and that the county and the city need to collaborate at a much deeper level. And I think that this could be a program that actually opens that door. I have great hopes in that regard.
Very good.
All right, everybody, the hour is late. We do have a closed session to get to. So I'd just like to say this, there was a request of direction to the city manager. Of course, the city manager is not present in the meeting, but it would be just simply to release the CARES Act money and get this program started. As you saw in Dr. Porteous's timeline, it actually is underway currently. And so the funding needs to be made available. That would be my direction to the city manager. And barring objections, are there any?
I second that.
Vice Mayor Chris Conlon sitting in for city manager, and it's noted.
Okay, thank you, Chris. All right, I think we've had enough of meth for today. Thank you very much for your attention, everybody. Meeting adjourned, and we need to convene closed session.